Thanks very much, Olivia. It's a great pleasure to be here and especially talking with Devin as well. So I was going to start off and then Devin is going to talk, and then I was just going to finish off at the end. And the things that we were going to cover today is looking at the sort of evidence, clinical and theoretical evidence about overlap between FND, suggestion, placebo, nocebo mechanisms. And Devin is going to talk about more empirical evidence for that. And then at the end, just thinking about what that means, I suppose, from a clinical point of view. So it's not a new idea, really, that hypnosis and suggestion may be a relevant thing in functional symptoms. So going back to Charcot, was very interested in hypnosis and thinking that suggestion could be used as a model for what at that time was called hysteria. And Janet also had an idea about some fixed ideas that people might have, so beliefs, I suppose we might call them, that weren't actually accessible to consciousness. And he often related these to previous traumatic experiences. So it's an interesting sort of historical fact, I suppose, with the development of interest in hypnosis and the development of interest in hysteria, conversion disorder, coming along at more or less at the same time. And that was taken through into older diagnostic categories of functional neurological disorder, where having remittance with suggestion or placebo was seen as the sort of highest level of surety that you could have that this person had a functional disorder. Now, that way of thinking about things, which if you think about it is rather a sort of somewhat negative way of thinking about things, has been replaced with the idea of positive signs, so that the symptoms and signs in people with functional neurological disorder have specific positive characteristics. For example, the distractibility of functional tremor. But it's interesting that this idea of remittance with suggestion and placebo has been there for a long time in the diagnostic criteria for these disorders. So just thinking about how that's played out in practice, there is a long history of using suggestion in the diagnosis of FND. There's also quite a long history of being anxious about using suggestion and being worried about what this might do. But here's an example from a paper by Jankovic about using effectively a nocebo suggestion. So this person's it's been suggested to him that his tremor is going to worsen with the application of a tuning fork.
It really makes it worse.
So there, lo and behold, he has a worsening of his tremor. So these sorts of techniques, so saying to a patient explicitly, we find in many people that this makes these sorts of movements worse, or sometimes this makes it better, has been used by many people as an aid to the diagnosis of FND. And in a much more systematic way, it's been used also in the setting of functional seizures or non-epileptic seizures. And this is trying to get around an issue in clinical practice where often it is quite easy to tell just on clinical grounds that somebody's having a functional seizure, but sometimes it is more difficult. And so ideally in that situation, you'd want to record EEG from the brain when somebody's having one of their seizures, and in a functional seizure, you wouldn't see any evidence of epileptic activity. But of course, some people only have seizures once a month, and that's hard to do. So here you would use suggestive seizure induction for people with suspected non-epileptic seizures. And here, nice paper by your very own Stoyan, Pokurov, showing how that can reduce the need for formal video telemetry being done. So the problems that people have raised with all of these things is that maybe the thing that you're inducing is not actually the disorder, but you are inducing something. So maybe you're inducing a dissociative or functional seizure in a person who's very suggestible, but actually they do have an underlying epileptic condition. And so all you've done is just induce a different thing. So you have to be very careful to, particularly with suggestive seizure induction, that the thing you've induced does actually look like and feel like to the person the same thing as their typical attacks. So this same idea of suggestion has been around for a long time in the setting of what's nowadays called therapeutic sedation, or used to be called abreaction. So here's a US Army video from the 1940s.
Sometimes an emotional disturbance shows itself as a physical ailment.
It's a nice calming music.
Here, an inner emotional distress has been converted into a form of paralysis. In this type of case, treatment under narcosis may yield extraordinary results. Here again, a sedative is employed.
But I'm not sure what they did, but it might have been Amityville, or might have just been benzodiazepines.
Under the influence of the drug, the patient's mind becomes more open and receptive. While the patient is in this highly approachable state, the doctor employs the power of suggestion to pave the road toward recovery. Now you're going to get right up and walk. Come on now, sit up.
That's one kind of suggestion.
Now get off the bed. Put your feet right down on the floor. That's fine. All right, now stand up. Isn't that good?
Yeah, I'm going to stop.
All right, now walk out there.
It goes on for quite a long time, but that's the so there was an idea with abreaction, going back to Freudian conversion theories, that what you would do is you give somebody Amityville, you'd get them into a twilight state where they would remember their repressed trauma, and then through the remembrance of that trauma, they would improve. Speaking to people who did a lot of abreaction in the days when that was done quite frequently, that very, very rarely happened. But what often happened was that symptoms improved under that sort of sedation, and that sometimes people got lasting benefit. So there's been more modern reports of that. And so here's John Stone giving propofol to get somebody into that same twilight state who has functional disorder. So she's got high so she can't move her arm. She's got no movement in her legs.
Putting your brain into a very strange state.
So the audio is a bit poor, but he's giving her lots of suggestions saying you can feel your arm moving, you can feel it getting stronger. Being video with her consent.
That's good. That's nice. That's good. Does it feel nice to feel your legs again like that? Feel them moving. Shows that they can move again. Up, down.
So that's on the board, and she's regained function. So this is the same sort of idea of using suggestion under narcosis. The same thing has been done with other things that have been around for quite a long time, but still nowadays. So using electrical stimulation as a way of demonstrating to somebody, I suppose, that their body can move. So that was something that was done a lot in the early 20th century and before, actually. So here's somebody coming back from the trenches in the First World War with a dragging gait. So it's a typical functional gait pattern. And then having some treatment, and this treatment was suggestion with electricity and sort of electrical stimulation, causing the limb to move. And there's been a lot of interest about that in using transcranial magnetic stimulation to do the same thing. And this was a really nice study from Beatrice Garcin, who's done a lot of work in that area, showing that you could get improvement in people's functional weakness, whether or not you gave the stimulation to the brain, to the motor cortex, or to the cervical roots. This was in the case of arm weakness. So because there had been a question about whether the TMS might be causing some kind of neuromodulation, etc. But it seems not to be that. It seems to be the experience of having your limb move when you have a functional paralysis can in some people improve the situation. So just thinking briefly about why that is. So human beings are definitely more than stimulus response organisms. So as you know, all of you very well, even if you take a really obvious stimulus like shutting your hand in a door, your conscious experience of that has to be mediated through the brain. And that's a dynamic process. So the experience of a conscious perception is a dynamic process. It's not just a readout of input. And we know that there's, broadly speaking, two sources of data that guide action and perception. So there's the feedback from our bodies, which is the bit that people generally think about being important. But there's also the predictions about that data. So this idea of top-down predictions or expectations about what you're about to experience. And with the idea that attention acts in a particular way to turn up or turn down the power of the attended source of data. And again, I know this audience is very familiar with these ideas, but that's why I put up this picture of people playing tennis. So the person about to hit the ball has quite a lot of sensory data, bottom-up sensory data from his visual system guiding his movement. But the people on the other side of the net are not just standing still, they're already moving based on predictions on where that ball's going to go. And the person back on the other side of the net is doing an even more kind of meta calculation about where this ball's going to go and then where these people are going to hit it. And he's already moving. So this idea of predictive processing is a really efficient way in which to guide action and perception. And that's that same idea of this dynamic predictive system has been thought about as a key mechanism behind placebo and nocebo effects. And so that's where there's this idea of a shared mechanism between functional neurological disorder, where it's proposed that there's a development of abnormal prior expectancies, which then guide action and perception. And the same thing happening typically in a transient way with placebo and nocebo, meaning that the experience is driven by the prediction, not on the sensory data that's coming in. And you can see that starting to make sense of common experiences in functional disorders. So it's extremely common for people with functional disorders to have a health event at the beginning. So that might be an accident, an injury, an operation, a drug reaction, all kinds of things. But it's an extremely common trigger to the onset of functional disorders. And of course, that trigger is a psychological event as well. And it's something which produces potentially an expectation about what sensory experience, what movement experience is likely to be like following that. And so integrating that in an explanation for F&D is really helpful and important. And just lastly, you can see that also even cross-culturally. So this is a lovely set of studies from comparing population studies, comparing Canada and Lithuania in the early 2000s and the late 90s. I'm sure this wouldn't be the case now, but at that point, people in Lithuania and people in Edmonton, which is in Canada, were asked what they would expect to happen if they had a minor rear-end traffic accident in terms of symptoms lasting for a few hours or days, for a few weeks, or for months or years. And you can see that most people in both groups say, well, I probably get some symptoms acutely. But in people in Lithuania at that time, hardly anyone was thinking that they might get a lot of symptoms long term. And at that point, the incidence of whiplash, so chronic neck pain after minor injury, was almost zero in Lithuania, but was very, very common in Canada. So this is an example of how population level beliefs or expectations can drive the prevalence of physical symptoms. So I'm going to stop sharing now and hand over to Devin for the middle bit.
So Mark has already covered quite a bit of this. So some of the initial points I'll go through fairly quickly. So the starting point here is really just the phenomenon of suggestion, and then we'll kind of expand upon how that relates to FND and broader dissociative psychopathology. But so we typically define, following Irving Kirsch and many others, as a suggestion as a communication for an involuntary response. So suggestions are typically phrased as something that is happening to you as opposed to something that you are willfully producing, right? So the canonical example, of course, is in the context of placebo effects, where a doctor tells her patient, this is going to make you feel better. So you're not telling them you're going to form an expectation and your expectations are going to modulate your experience, right? They're misattributing agency to the external source, right? And so, of course, you can produce placebo effects without suggestion, but suggestion is often a fundamental feature of placebo effects. Obviously, it's present in a number of other phenomena, most notably hypnosis, which we don't think hypnosis is anything particularly unusual. I just like to think of it as a way of harnessing verbal suggestion within a very specific kind of socio-cultural context. And then finally, of course, nocebo effects. And you heard from Tim Nicholson a couple of weeks ago about suggestion and nocebo effects in response to vaccines and so on. I probably don't need to convince this audience about the power of suggestion, but just briefly, we know that suggestions can produce pronounced changes in perception, even in the absence of any kind of formal sham procedures, just suggestions alone. One of the most striking examples of this is the use of suggestion to reduce pain during surgeries. So this is typically done most often with hypnosis, but one study in the British Medical Journal didn't even use hypnosis and just randomly allocated patients undergoing surgery to a suggestion condition for reduced pain versus a control condition where they would just listen to a voice speaking to them, right? Now, what you can see is in the intervention group who received the suggestions, they experienced significantly lower pain throughout the surgery at various phases and up to as far back later on as 24 hours. And importantly, this is also associated with lower drug intake during our need for drugs during the surgery. So clear kind of clinical impact, which often has positive outcomes in the wake of the surgery as well. And then if you look to meta-analyses, a number of meta-analyses, again, just in the context of using verbal suggestion alone for pain reduction, have found highly significant effects, typically in the range of moderate to even high effect sizes. These have been observed in both experimental studies, but also importantly in clinical studies as well. So it really just kind of speaks to the importance of or the value of suggestion in a range of contexts. Now, what's not always fully appreciated is that people vary radically in how they respond to suggestions, right? And so suggestion is often framed in a kind of an overly simplistic way with kind of a bit of ignorance of the trait individual differences. So the primary kind of trait individual differences variable that we're interested in is what we typically call direct verbal suggestibility. So this is just your capacity to respond to verbal suggestions. And it's important to emphasize this is typically measured with standardized behavioral scales where you actually administer a set of suggestions and then observe someone's behaviors. So it's not like a typical kind of questionnaire measure where somebody's kind of retrospectively rating their kind of day-to-day life experiences. So we know that this is the most kind of reliable predictor of responsiveness to phenomena like hypnosis. And this is a bit controversial, but there is some evidence that it weakly predicts placebo and nocebo responding. All right, I don't want to make strong claims about that because there's quite a bit of controversy, particularly about the notion of a good placebo responder or a good nocebo responder. My reading of this literature is that if you have a fairly robust suggestibility scale and you have a fairly robust behavioral measure of placebo and nocebo coupled with good statistical power, i.e. a large sample size, those studies tend to find a weak correlation, right? Other studies that have kind of poor methodology, those are the ones that typically find kind of no effect. So I don't think this is any way a robust effect, but I think there is basically a bit of a consistent kind of weak prediction where suggestibility tends to predict these effects. So we show this in a paper that's currently under review, but it's on medRxiv that suggestibility is related to the nocebo effect when you aggregate all the studies, for example. Now, importantly, this extends beyond placebo and nocebo effects also to active interventions. One of the most striking examples of this from the last year was a study showing that suggestibility predicted the antidepressant response to psilocybin. All right, so this is one of the big RCTs that got a lot of attention. The original paper was published, I think this was the New England Journal of Medicine paper. So here they compared escitalopram and psilocybin for individuals with treatment-resistant depression. On the y-axis, you can see their change in depression scores over a 6-week period. On the x-axis, you can see their baseline suggestibility levels. And as you can see in red, the more highly suggestible people in that bottom right-hand corner were the ones that exhibited the most pronounced antidepressant response to psilocybin. Now, critically, if you look to the upper top left corner, right, and you look at those 4, 5, 6 least suggestible participants, they basically had almost no antidepressant response to psilocybin, right? And critically, if you look at the blue line, suggestibility did not predict response to escitalopram. There's a number of reasons to explain this, and I'll be happy to elaborate upon that. And there's a number of different ways to interpret it. Nevertheless, it kind of points to the value and the importance of suggestibility in response to a range of active treatments as well. So Mark has already kind of done some of my work for me, just in terms of kind of this historical link between dissociation and suggestion. So we typically define dissociative symptoms as some type of disruption between normally integrated systems supporting awareness, emotion, memory, identity. Kind of the canonical examples would be depersonalization, derealization, dissociative identity disorder. This, of course, also extended over to functional neurological disorder. So we have this kind of canonical image of Charcot with an FND patient. And so kind of two of the emerging ideas that came out of the end of the 19th century and earlier were first that if a symptom could be modulated through suggestion, then it was indicative of what they then called hysteria, or what we would typically refer to as functional neurological disorder. But also that a high level of suggestibility is often indicative of some type of level of dissociative psychopathology, right? That's kind of the belief that came out at the end of the 19th century, this kind of close coupling of a high level of suggestibility with dissociative and functional symptoms, right? Now, in the 20th century, however, and particularly over the last in the last couple of decades, this view kind of went out of favor, particularly with regard to kind of the etiology of dissociative symptoms and dissociative disorders in particular. So one of the big debates that's been going on in the field recently is between two competing models of the dissociative disorders. So the first is the trauma model, and the basic idea of the trauma model is that dissociative symptoms and dissociative disorders arise from adolescent trauma exposure, okay? A fairly simplistic model, and it's important to emphasize there's a wealth of data that are consistent with this, so I'm not in any way challenging that type of model. The kind of competing model that arose out of this is typically referred to as the social cognitive model. And the basic idea behind this model, which has been incredibly controversial, is that suggestibility functions as a causal, as a kind of a causal role in developing false memories and symptom misreporting, and these lead to diagnoses of dissociative disorders. So this is kind of framed within the whole kind of false memory debate that emerged in the 1990s. And the basic idea here is that suggestion is functioning as a kind of a causal factor in the development of these types of symptoms through processes like iatrogenesis, where a therapist would kind of give suggestions that a patient has a trauma history and give them and induce symptoms of like dissociative identity disorder and so on. Okay. Now, the reason why this model and this debate is interesting in the present context is because these two camps have been debating about the role of suggestibility. And importantly, recently they developed a consensus between these two camps that suggestibility is not actually in any way atypical in the dissociative disorders. So both this 2019 paper and a recent 2021 paper, there's consensus emerging in this field. Now, we were kind of perplexed by this because we know there's this long-standing historical link between dissociation and suggestion effects that's been observed in a wide range of contexts. So we were then kind of intrigued as to why this was the case. So when we dug deeper into this, we kind of realized that they were kind of making fundamental misconceptions about suggestibility, and this is a really kind of a salient issue. So suggestibility, unfortunately, we're using in a very general sense, but when I'm talking about suggestibility, I'm referring to a very specific form of suggestibility, which we typically, again, call direct verbal suggestibility. Here, I'm depicting that at the top is an individual's capacity to respond to these simple direct verbal suggestions that are present in hypnosis, placebo, and so on. On the bottom, we have what we typically call interrogative suggestibility. That's how an individual responds to leading questions, interrogative questions, typically in an interrogation or forensic context. Now, what we know is that these two forms of suggestibility are actually completely independent of one another. So all the data, all the factor analytic work, all the experimental work consistently indicates that direct suggestibility, the kind that we're interested in today, is completely independent of this indirect suggestibility, right? Now, what's striking is when you look back to the recent consensus about suggestibility in the dissociative disorders, and they drew on this body of evidence to argue that the dissociative disorders are not characterized by elevated suggestibility, guess what they did? They only considered the interrogative measures. And indeed, you do find that patients with dissociative disorders are not more responsive to measures of interrogative suggestibility. Interestingly, as a side note, patients with schizophrenia are. So the dissociative disorders and schizophrenia patients diverge on these types of measures. By contrast, there's no mention of direct verbal suggestibility, even though there's this kind of long-standing historical link. So over the last few years, we've pursued a number of meta-analyses to kind of probe this question. So first, we looked at elevated suggestibility, or whether there was elevated suggestibility in functional neurological disorder. And we found fairly consistent evidence for this. So on the left are the effect sizes for standardized measures of suggestibility. These are the standardized scales that are typically used, such as in the hypnosis field and in the assessment of non-hypnotic direct verbal suggestibility. As you'll see here in blue, the effect size is basically what we consider to be a half a standard deviation, so kind of like a moderate effect size. So nothing incredibly strong, but there's a clear-cut effect there. On the right are what we're calling symptom suggestibility. So this is the same procedure that Mark described earlier, where they typically use a nocebo induction procedure to trigger a symptom. And what you find is that typically relative to clinical controls, often epilepsy patients, here we have a large effect of 1.4 standard deviations. This is typically what we would consider to be a fairly large effect. As Mark correctly pointed out, this does not meet the high standard of being able to be used for diagnostic purposes alone. So the sensitivity is actually quite poor. The specificity is actually quite good. So you typically only have maybe about 5% of epilepsy patients responding to this, whereas in FND patients, you often have something like 50%. So then the question becomes, does this extend to other types of domains? And so one thing that we've been intrigued by is to what extent does this extend to placebo and nocebo effects in the domain of pain, for example, or is it kind of specific to their symptom profile? So some of you may know there's an interesting kind of effect described nicely in this paper here, where when you do a placebo experiment, a small proportion of participants display a nocebo response. So in this study, in both healthy controls and patients with chronic pain, it was typically in about 8 to 12% of patients, even though when they're given a placebo procedure for reduced pain, they end up displaying a nocebo response. So in a study that was run by Mark's group, here the reference at the bottom, they found kind of some preliminary evidence that FND patients displayed a weaker placebo response. But it was kind of a little bit kind of mixed in terms of the evidence, but it was kind of hinting at that. So recently with Mark, we've been looking at the data and we framed it in the kind of the same way that they did in this study to look at what is the proportion of patients who are displaying a nocebo response in response to placebo hypoalgesia, so reduced pain through verbal suggestion and a cream applied to the arm. And importantly, we basically found in the controls that it was about 10%. So it's very similar to what was observed in this previous study on the left, whereas in the FND patients, it was 30%, right? So a threefold kind of increase. Now, bear in mind, this is small sample size, preliminary analysis, so we don't want to make strong claims on the basis of this, but it's certainly interesting and may point to kind of some preliminary evidence for elevated nocebo responding in FND in the context of pain. Now, the next thing we were interested in is to what extent do these effects generalize beyond FND? Is this something that's specific to FND, or is it a broader feature of germane conditions? So then we looked at how participants are responding to these standardized suggestibility scales in different psychiatric conditions. And we were only able to examine in this study dissociative disorders, trauma and stressor-related disorders, which is primarily PTSD, and then again, FND. And what we found is in all three cases, they're characterized by elevated suggestibility. These are all hypnosis studies, I should say, because there's a bit of a bias in the literature where people are only using hypnosis for this purpose. And this is a fairly robust and fairly large effect size. Now, one thing you might notice from the trend at the bottom is that the effect is larger in the dissociative disorders than the trauma and stress-related disorders, and then FND is at the bottom. And we think this kind of hints to kind of suggestibility may relate to heterogeneity in dissociative symptoms across these different populations, right? Because the dissociative symptoms are obviously most pronounced in the dissociative disorders, then next in PTSD, and then next in FND. And some further evidence from this comes from basically a lot of the studies actually report the correlation between suggestibility and dissociative symptoms or functional symptoms within the samples. And so this is something you also consistently see. So in all these studies here, what you find is that suggestibility correlates with either dissociative or functional symptoms within the actual clinical sample, right? And one thing I want to highlight just briefly is this paper by Millman and colleagues. This is our old study where we looked at depersonalization, derealization disorder. And what's interesting is we did not find any evidence for elevated suggestibility in that sample. And I'm happy to say why that might be the case. We actually find Bayesian evidence in favor of the null hypothesis, so no effect at all. But what was striking was even though they didn't display elevated suggestibility, we still found that suggestibility positively correlated with dissociative symptoms in the DDD sample, right? So it still accounts for variability in dissociative samples in a group that's not characterized by elevated suggestibility, right? So again, it may account for heterogeneity in dissociative symptoms. So then finally, the last effect that I'll briefly describe is a very fascinating phenomenon, of course, of mass psychogenic illness. This book I would strongly recommend, Havana Syndrome by Below and Bartholomew. This is very salient to my mind on the day of the US election, unfortunately. But so this is this phenomenon of Havana Syndrome where my government, the US government, came to believe that the Cuban government was attacking the US embassy with supersonic weapons, which of course did not exist. And most of the medical experts have come out to conclude that this was evidence of a mass psychogenic illness of social transmission of symptoms. Now, unfortunately, there hasn't been a lot of systematic research on mass psychogenic illness in with more kind of rigorous experimental or controlled studies. But one of the nicest studies that's been done in the last few years is a paper by Sepkoda and colleagues, where they compared children that were all from the same school, compared those who displayed symptoms of MPI versus those that did not. And they looked at a whole host of variables to predict if they could predict whether somebody displayed symptoms of MPI or not. And importantly, they had a very large sample size, about 200 children in total. So they looked at all these different variables like neglect, abuse, contagion effects, dissociation, so on. And what was very striking is the best predictor of all these was hypnotic suggestibility. Right. So that was actually a better predictor than post-traumatic stress symptoms, dissociative symptoms, trauma, and so on. So again, it reinforces how suggestibility is an important kind of variable to consider in these contexts. Okay, so I'm going to pass back to Mark.
Thanks very much, Devin. So just briefly to conclude, because it would be great to hear your views and questions. Just thinking about what this means, particularly in clinical practice, actually. So let me just put it on full screen. So I think that it's clear that these effects are important when it comes to clinical practice. And there's been a lot of work done thinking about how to communicate the diagnosis of functional neurological disorder. This is one of my favorite papers about that because it presents it as a sort of photo story. But it's basically the idea that one can present the diagnosis of functional neurological disorder in a way which is honest and truthful, scientifically valid, but is also therapeutic, and that there is a significant nocebo effect of the way that these disorders are characteristically explained. There's also been work thinking about hypnosis as a treatment in the setting of functional neurological disorder. And I think one of the things to highlight, I suppose, is that hypnosis, certainly in the UK, is often thought about as a slightly mysterious thing that you might have to go through lots of training to be able to perform. But as Devin has suggested, or said and suggested, it's a form of suggestion in a sort of particular social cultural context. But we can use these sorts of things, and most clinicians do use these things all the time in the way that we might communicate with people. But actually learning that and learning the reasons why these things work could be useful in terms of medical consultations generally. There's been remarkably little in terms of formal study of hypnosis as a treatment for functional neurological disorder. This paper from 2022 was a person in a stroke unit where there's many people who turn up with functional stroke-like presentations. About 10% of people admitted to stroke units have that. Finding that the application of hypnosis in an acute fashion seemed to be particularly helpful for people with functional stroke. A small study, but I think an important one, and showing how you can implement these things in clinical practice. And there are some older studies about including hypnosis as part of a treatment, often combining it with specialist multidisciplinary treatments, which shows some additional benefits in some studies. So here are just a couple of examples of situations where people have used hypnosis, or ways in which you might be able to apply hypnosis or at least suggestions in clinical practice, and the ways that people might be able to learn that themselves. Again, trying to, I suppose, demystify this and demonstrate that probably many clinicians, even though they don't realize that they are using these sorts of techniques in successful clinical practice, both in terms of diagnostic explanation and in terms of treatment. And coming back again to abreaction and suggestion under narcosis, here's a very nice paper by Norman Poole and others, sort of looking at the history of that and what the available evidence is, and finding that really so much of this is about suggestion under narcosis, and that might lead people's symptoms to reduce at that time, but also when the narcosis is removed. So just thinking about that in clinical practice, here's somebody who's got a fixed chronic posture. She's about to receive botulinum toxin injections. She is really going to receive botulinum toxin. If you know anything about Botox, you know that to block the neuromuscular junction takes a couple of days usually. She doesn't know that. She's had quite a lot of suggestion that this is going to be effective. And so there's an effectively curative placebo response. So I have over time used Botox quite a lot in clinical practice, and I've sort of initially thought that this was the answer to things, but I think that most people that I've treated in that way relapse, so they get a return of symptoms, then the placebo or the Botox doesn't work. And some people become very, very dependent on it. And even when you explain to them it's a placebo, it's quite a difficult conversation to have. And I think that sometimes people talk about deceptive and open placebos, but there is this issue about getting better by magic and without self-efficacy. And I think that that's an important issue when it comes to using suggestion in clinical practice. We need to think about how to get around that as an issue. And just to finish with, I think it's really important, beyond the idea of using suggestion or hypnosis in clinical practice, it's just to think about the very, very strong nocebo effects of what we usually do. So if you think about typical patient encounters for people with functional neurological disorder, they start in a very normal way with a normal set of expectations, where a patient goes to a doctor with a problem and the doctor does something normal depending on how acute or severe the problem looks, like sending them to the emergency room or a stroke unit or to an outpatient clinic. But then there's a whole load of problems that happen in terms of usually the diagnosis being made, but often not explained, or being explained in a way that makes it sound like there's nothing really wrong. There's no real pathway often for referral of those patients, so they don't really go anywhere in particular. And because these patients confront doctors and other health professionals fundamental ideas about, for example, the distinction between physical and mental illness and so on, often they make doctors feel quite upset and angry, and that then translates into a bad encounter. And then even if people are referred, there's a huge number of places they could possibly go to. And usually none of these places talk to each other. And often people turn up in those places and are told, actually, this is not the right place to you. You need to go somewhere else. So what you end up with is a situation where those services don't work together and are not integrated. And you have this enormous expenditure and activity. So a lot of money being spent, a lot of things being done. But then a really poor quality of life for patients, feeling stigmatized and alienated from healthcare and without any real idea of what they can do. So that's, I think, the real major nocebo effect that we need to challenge in clinical practice for people with FND. So I hope that you enjoyed those talks, and Devin and I will be very happy to answer any questions. Thank you.